Hi there, Marius here with the Resuscitation Coach. In today's video, we will review the ACLS Cardiac Arrest Algorithm based on the 2025 American Heart Association guidelines. I will include a link to the 2025 AHA guidelines in the description below. We always have to start with our basic life support. BLS is the foundation of our ACLS. If we do not perform good BLS, our ACLS outcomes will be poor. The first step in our BLS sequence is to check for a response. Tap and shout, "Hey, hey, hey, are you okay?" Check simultaneously for a pulse and breathing for 5 to 10 seconds. If the patient is not breathing or does not have a pulse, immediately activate your local emergency system and begin with high quality chest compressions. High quality CPR includes pushing hard, pushing fast at a rate of 100 to 120 compressions per minute, pushing down at least 2 inches or 5 centimeters, allowing for full chest recoil and not interrupting CPR unnecessarily, and giving just enough air to see visible chest rise. Once your crash cart or defib arrives, immediately attach it, as we want to hunt for ventricular fibrillation or pulseless ventricular tachycardia. Immediately perform defibrillation if you see ventricular fibrillation or pulseless ventricular tachycardia. Remember that for every minute we delay defibrillation, the chance of survival decreases by 7 to 10% per minute. Deliver your first defibrillation by following the manufacturer's recommendations, as what you see here on the screen. Immediately resume high quality CPR after each defibrillation. Insert an IV or an IO if an IV is not possible, and start preparing our first medication. Our first cardiac arrest medication is going to be epinephrine, 1 milligram of the 1 milligram in 10 ml concentration or 1 in 10,000. After 2 minutes of CPR, analyze the rhythm, and if it's still VF or pulseless VTac, immediately defibrillate for the second time. And resume high quality CPR for another 2 minutes. We have now defibrillated twice and can administer epinephrine, 1 milligram IV push, followed by a 20 ml saline flush and elevating the extremity. In VF or pulseless VTac, the recommendation is to administer epinephrine only after the second defibrillation, as we are focusing on the most important steps. It's high quality CPR and defibrillation. At this stage, consider placing an advanced airway and using waveform capnography. Waveform capnography can help monitor tube placement, but can also help us to monitor our CPR quality. We will also have time to prepare our next medication, which is amiodarone, 300 milligrams IV push, or lidocaine, 1 to 1.5 milligrams per kilogram. After 2 minutes, we need to review the rhythm. If it's still VF or pulseless VTac, we can deliver our third defibrillation and immediately resume CPR for another 2 minutes. After the third shock, we can administer the amiodarone or lidocaine IV push. Most clinicians will use the big A, but there's a lot of debate on which is better. In Circulation in 2019, a study by Wagner et al. Compared amiodarone to lidocaine for in-hospital cardiac arrest and found it was not associated with higher ROSC rates, but lidocaine was associated with higher 24-hour survival, higher survival to discharge, and favorable neurologic outcomes. In November 2022, in Chest Journal, Wagner et al. Published a comparison again and found that lidocaine was associated with higher ROSC rates, 24-hour survival, survival to hospital discharge, and favorable neurological outcomes. In the 2025 AHA guidelines, you can use either amiodarone or lidocaine. We should also never forget to consider our reversible causes of cardiac arrest, our 5 H's and 5 T's as listed here. At this stage, we should prepare our second dose of epinephrine 1 mg. After our 2 minutes of CPR, we need to defibrillate again and, if indicated, and continue with our high quality CPR. After the fourth defibrillation, we can administer the second dose of epinephrine, 1 mg IV push, and resume high quality CPR. We need to get our next medication ready. Amiodarone, 150 mg, or lidocaine, 0.5 to 0.75 milligrams per kilogram. Note the lower dose for both amiodarone and lidocaine. After our fifth shock, we can go straight to administer our amiodarone or lidocaine IV push, followed by a flush. Pay special attention again to the lower dose this time. In the VF or Pulseless VTac algorithm, we follow the following pattern. Our initial priority is high quality CPR and defibrillation. We will only give our first epinephrine following our second shock. After our third shock, we will give amiodarone or lidocaine. After our fourth shock, we will give another epi. After our fifth shock, we will give another amiodarone or lidocaine. The way I remember the shockable algorithm is to give epinephrine after the equal number of shocks and amiodarone or lidocaine after the odd number of shocks. By following this pattern, we will give 1 epi every 4 minutes and 1 amiodarone or lidocaine every 4 minutes, which falls within the AHA recommendation of every 3 to 5 minutes. Let's review our non-shockable cardiac arrest rhythms. The treatment for asystole and pulseless electrical activity, or PEA, is the same. If you find asystole, ensure that it's a true asystole. Follow the flatline protocol, check the ECG leads, and ensure the defib is set up correctly. Immediately obtain IV access or IO if IV is not possible, and prepare your first medication, which is epinephrine 1 mg. We can give epinephrine 1 mg IV push every 3 to 5 minutes. In asystole or PEA, we want to give the epinephrine as early as possible, as it's been shown to improve outcomes. Consider an advanced airway with waveform capnography, and don't forget our reversible causes. If you benefited from this video, kindly like, subscribe, and smash that notification bell. We'll see you in the next review video. Have a fantastic day.